Hello, everybody. Welcome. Good morning and happy Friday. Hope everybody had a nice Thanksgiving. Welcome to the Informatics Institute PowerTalks series. I'm very happy to introduce today's speaker. Many of you know him or have worked with him and his initiatives. So Dr. William Hogan, he goes by Bill. He's director and professor of the Division of Biomedical Informatics in the Department of Health Outcomes and Biomedical Informatics. Also director of biomedical informatics for the Clinical and Translational Science Institute at the University of Florida. And in addition to that, probably he's even better known, director of informatics for the statewide OneFlorida Clinical Research Consortium. So he's also one of the co-principal investigators of that. And it's Florida's member organization of the National Patient-Centered Clinical Research Network, or PCORnet. OneFlorida is just one of 9 clinical research networks in the PCORnet 2.0 nationwide. He has over 20 years of experience in developing and implementing large informatics systems, EHRs, and data warehouses. He's an accomplished researcher, practitioner, biomedical informatics, and researcher working in terminologies, ontologies, EHRs, biosurveillance. He has over 60 journal publications and peer-reviewed papers at conferences, and has been a PI or co-PI in over $90 million of grant funding. Before University of Florida, he was at University of Pittsburgh, and then also University of Arkansas. He did his bachelor's studies at Pennsylvania State University, and MD at Jefferson Medical College, and PhD, master's at University of Pittsburgh. And the title of his talk, OneFlorida Plus Informatics, Infrastructure and Tools to Accelerate Clinical Research.
Great. Well, thank you for that introduction. Thank you all for coming. I need to update that bio a little bit. Because we're in PCORnet phase 3.0 now, and we're down to 8 clinical research networks. So I'm going to go, So I'm going to start by talking about OneFlorida Plus and then get into the informatics bits. So OneFlorida Plus, as I just mentioned, we're one of 8 clinical research networks in the National Patient-Centered Clinical Research Network, or PCORnet. And this is kind of a coverage map that I took directly from PCORI's website. So the green areas are denser or higher coverage, and the light purple areas or white areas are lower, no coverage, respectively. So you can see, we have good coverage in Florida, reasonably well statewide, highly concentrated in the center of the state, which reflects our own location and the fact that we include 2 large health systems from Orlando and other parts of the center of the state. So OneFlorida we describe as an enduring infrastructure and capacity to carry out various research activities, such as identifying study populations, comparative effectiveness research, comparing different drugs or devices or procedures. Doing trials in the real world, we tend to focus more on pragmatic trials, and also translation into practice and implementation science, and involves a lot of partnerships with people, clinicians, health systems, payers, and so on. So this slide just talks about real world data, and we do, the reuse of electronic health record and claims data really does fall into the wheelhouse of real world data. And in OneFlorida, as I'll talk about later when I talk in more detail about the data trust, we do have all data from each of these example sources I have listed here. And just, the FDA definition of real world data is on the screen, relating to patient health status and or the delivery of healthcare routinely collected from a variety of sources. So OneFlorida Plus is statewide in Florida, and we've expanded to Alabama, and that's why you're all here. So UAB joined OneFlorida during our phase 3 funding that began in January, and your data is now part of the OneFlorida Data Trust, and also Georgia. So we added Emory as part of the new round of funding. We also added USF and Tampa General in Florida, so that also intensified our green color in the center part of the state. And you can see the list of the other partners. We also have some health claims data from a private insurance company called Capital Health Plan. We have statewide Florida Medicaid data from our Agency for Healthcare Administration. And we're in the discussion. We have the linked mother-baby data from the Department of Health. And we're in discussion with them to add a bunch more data, hopefully in the near future. So I want to just, for those who may not know what PCORnet is overall, I'm going to switch to another deck because I couldn't merge the templates. I apologize for that. Whoops. And let me know if you cannot see the PCORnet slides. I can stop and restart the share. Yeah, I'm guessing that did not happen, did it? All right. Okay. So these are from stock slides from PCORnet, and I won't spend a lot of time on them. But for people who don't know what PCORnet is, it's important. So PCORI saw room for improvement in clinical research, you know, the typical problems we all know and talk about. Often doesn't answer questions don't matter to people, populations aren't representative. It's expensive and slow, we don't complete enrollment, and so on and so forth. So PCORnet was created to fix those problems. So it's a network of networks. So OneFlorida Plus is a network, but we're one of 8 networks in PCORnet, which is a network of networks. So there's another network in New York City. There's another network in the Midwest called the Greater Plains Collaborative, and so on. And we wanted to streamline processes and make it patient-partnered or patient-centered. So we have the 8 clinical research networks. We have patient partners that each network brings to the table, and a coordinating center that's a partnership between Duke and CHOP in Philadelphia to create the overall infrastructure for people-centered clinical research. This is just the motivation they give for why we need a network of networks. It's sort of a ground-up approach to build this infrastructure. PCORnet has a front door. OneFlorida also has this front door, and that's an interesting discussion we're having PCORnet-wide, is how investigators access things. For now, I'll just say, if you're interested in using OneFlorida, come to us. If you think you have a study, even if you think you have a study that might use multiple networks, we'll help you go through the PCORnet front door if that's the best path for you. So this is a nationwide map that shows the other networks and where they're headquartered, and then the same colored dots are where their partner sites are located. And then this is an old version of the colored map I showed you earlier. It's just a different, more perhaps choppy, granular view of what I showed before. It hasn't been smoothed out. The data have to be usable. So this is a fairly reasonably honest look at what's ready for research in PCORnet as a whole, and what's available but still evolving. And in OneFlorida, I would say this is true also, although we might be a little further along in geocoding and tumor registry, although it's site by site. And it has to be secure, obviously, because we're dealing with protected health information, and we need to be able to query things. So there's a way to query the data in PCORnet that I'll talk about a little bit later. And because it's PCORI funding, sorry, did somebody have a comment, or is that just an echo? Okay. Patients are at the center of what we do. So we want patients to be involved in the entire research process, everything from question formulation to study design, protocol development, helping us recruit and answering the questions that matter most. So one example of a PCORnet study, and I'll talk about other examples of studies done in OneFlorida, but is preventable. So this is an ongoing study. We've enrolled 20,000 patients already, age 75 and older. It's a pragmatic trial design using EHR and Medicare data plus phone surveys. Medications are shipped directly to patients. And so the strength of PCORnet is a one-stop shop process for capturing 3 complementary sources of data that would have been more, too cumbersome perhaps to do otherwise. And the question obviously is, it's a statin study. So can taking a statin in adults over the age of 75 prevent dementia? So statins are typically used for heart disease, but they're shown to have beneficial effects on inflammatory related diseases generally. And so do they have a beneficial effect on dementia? And we don't know the answer yet. Although we do have some results that are more about the process. So when we started Preventable before the pandemic, so when COVID-19 started, we needed to amend the protocol to add a telehealth visit. And so we only had to do that once, as opposed to once everywhere, times all the sites where the study is going on, and it's probably dozens of sites by now. And then PCORnet's embedded expertise was very valuable. And by embedded expertise, we're talking about you all, investigators at sites in PCORnet network. So investigators at UAB, investigators at Emory, investigators at UF, investigators at Miami and other sites. Help support and strengthen best practices for rapid enrollment. We had a New York Times article mentioned, AARP publications, and local senior guides. So I think that's it for PCORnet. The URL is easy to remember, pcornet.org. I'll go back to the other presentation now and start talking about the data trust, which is really the meat of why we're here. All right, so are you seeing full screen mode?
Yep.
Okay, great. So the data trust, and this slide's gonna animate itself for a little bit, but basically we bring in data from multiple sources, and that's the orange boxes that are populating on the left. So we have electronic health record data. We have some patient reported outcomes and other data that's collected as part of studies. We have the linked mother baby data from the state of Florida. We do some geocoding. A lot of our sources give us 9-digit zip codes, which we then are able to, we have a PhD geographer who helps us map those to census tracts. And maybe even she's able to map them to block groups because 9-digit zips are very precise. We have Florida Medicaid data statewide. We have some Medicare data for the dual eligibles, and a couple of our partners in Florida have given us a finder file to get Medicaid claims data. We also work with a company called Datavant. They do a great job of getting comprehensive death indicator data from around the country, both from the national death file, as well as they scrape obituaries from websites, from news organizations around the country. And then that all comes into the data trust. The data trust is physically at the data center at UF here in Gainesville. So what we have here is a HIPAA limited data set, and by limited, it just means we have only 2 categories of identifiers of the 18 HIPAA categories. So we strip off 16. And the 2 categories we have, I already mentioned. One is zip codes and the other is dates. So dates of service, dates of birth, dates of death. And we do enable people to query the data. in various ways, and I'll talk about that. And then once you have a query and you know that you have sufficient patient population, you can submit your protocol to the OneFlorida Executive Committee for approval. And once they approve a study, each site does maintain honest brokers that if you do have IRB approval, those patients can be re-identified and contacted through whatever IRB approved mechanisms you have, usually through a provider who's also a study investigator, to recruit. We do not contact your patients. Only you at your site contact your patients. And so we designed it that way from the start. So that shows the overall model. Besides electronic health record data, I mentioned on the previous slide some of these. So we have statewide Florida Medicaid claims, the date of aunt death data. Some of our sites do submit to us with the same submissions they make to the statewide cancer registry. And we include those. I mentioned the linked mother-baby data. So these are linked through vital statistics. So we have the mom and baby record through the birth certificate. That also gives us health conditions of the mother and the baby, and also whether the mother or baby died during the peripartum. We're increasingly working with third-party data sets and linking them through geography. So American Community Survey, we can compute various deprivation indices, for example. We've done that in the past. We've worked with the faculty in epidemiology who's subsequently gone to Harvard, but we still collaborate with him on bringing in a lot of third-party environmental indicator data sets, like particulate matter 2.5, for example. And water quality, we have some sources of water quality data, walkability indexes and so on. So these numbers are relatively current. We did just do a refresh of the data in October. So the numbers are still evolving. Sorry, that slide animated itself. So we do have about 19.5 million patients total. The epic date, if you will, is roughly January 1, 2012. Most of our partners give us a retrospective data set back to then. One partner started their EHR in May of 2012, so it goes back to then. The Medicaid data go back to 2012. I apologize for the slide keeping advancing itself. But you can see the other numbers about procedures, diagnoses, prescriptions. The numbers are huge. It's a huge data set. And quite rich and reasonably comprehensive around the state of Florida, and now increasingly Alabama and Georgia. We do harmonize the data into the PCORnet common data model, which is now on version 6, which is required by PCORnet. Mostly, though, we dump the PCORnet common data model data as SAS files. Most PCORnet queries come as SAS code. We have a big SAS server that's already straining under the load because the data are getting quite large. We're starting to migrate to the OMOP common data model. We're currently migrating to version 5.4. And the reason for OMOP is OMOP is really taking off. OMOP stands for Observation Medical Outcomes Partnership, which is an organization now known as Odyssey for Observational Health Data Sciences. And I forget the I, maybe, and Informatics. The I is Informatics. And so this is a worldwide community now that's really taking off and is developing a lot of great tool sets and shared tool sets and doing a lot of great studies where they're able to look at answer questions even beyond just the United States. So we want to be part of that community. Many PCORnet clinical research networks really keep their data in OMOP primarily and subsequently automatically convert it to PCORnet. So we're moving to that model as well. And we Emory, Miami, and Morehouse are a healthcare provider organization funded as part of All of Us research program. And so we really started getting our feet wet with the OMOP Common Data Model as part of that effort because all of us requires OMOP. So you can see even in an NIH, OMOP is getting a huge traction and mind share through the All of Us program. And we've been onboarding new partners in OMOP, beginning with USF and Tampa General. And I think we've asked your technical folks for OMOP data submissions. And I already mentioned about the general community and PCORnet. Also on data harmonization, we also want to do patient duplication or record linkage, or I think the term of art in the community now is entity resolution. So we do that through a privacy preserving approach. And the way that works, so if you have two OneFlorida partners that both have taken care of the same patient, say Jane Doe, but their data about Jane Doe are formatted differently and codified differently. There's an initial process that harmonizes and normalizes the data, so all the names are in the same case, uppercase or lowercase. I don't actually know what Datavant does, and formats all the dates the same, and codes the genders and race information the same. And then applies a one-way hashing algorithm that's based on encryption technology to generate a hash or a scrambled text, but we call it a hash. And so the two health systems, if they do that the same way, will generate the same hash. And it's as difficult to go backwards from that hash to the source as it is to unencrypt data without a key. So it's very secure. And then there's layers of encryption added on for additional security to prevent dictionary attacks. But then we can link Jane Doe's data to her. And so, for example, with the death data, we've linked the death data to about 250,000 of the nearly 20 million people. So that's a brief, quick overview of the data, how we normalize it, how much of it we have, what it is. So now I can go on to give a couple examples of studies that are using data. National scope studies, I mentioned All of Us already. We're providing electronic health records data for enrolled participants in the OMOP Common Data Model. We, like many of other sites, and probably you already, are participating in the National COVID Cohort Collaborative, or N3C. We also are part of, and I think your site's one of the 5 OneFlorida sites participating in NIH Recover and CDC COVID. The CDC initiative is funded through the Public Health Informatics Institute from the CDC. They really wanted data to be refreshed more frequently than monthly, so they're asking for bi-weekly data refreshes. And then on NIH Recover, again, using the OMOP Common Data Model, and we're submitting data to Weill Cornell. One of the PIs on that initiative is a PCORnet PI for the New York City CDR Clinical Research Network, Renu Cashel. And then there's a pediatric one also in PCORnet for Recover, and that's led by Chris Forrest, who's the lead PI for the PedsNet Clinical Research Network in PCORnet. And then N3C obviously has a big role to play in the Recover study as well. In terms of numbers, we've had about 13,000 prep to research data requests. 13,000 of those are through the I2B2 system. So we do have an I2B2 system for all of OneFlorida. We have multiple projects. So in our I2B2 instance, so one project is the huge linked data set with all the privacy preserving record linkage, all 12 or 13 sites, data combined. Roughly 20 billion facts by now. We've had to use specific database sharding technology to make that work, if you know what that means. And so it's a huge lift. Your data, is not yet in the I2B2 instance. It will be soon. We're having those discussions now. I don't have an ETA today, unfortunately, but I will have an ETA before the holiday break, and we'll follow up and get you the ETA for when that will be available. I know we've had a couple requests from UAB investigators to get access to the I2B2 instance of OneFlorida, and so we're working hard on that. We have query coordinators to help support queries. So if you want to ask questions of the data before you have access to I2B2, by all means, come to the OneFlorida front door and ask us. We'll help you work on that. We've had 136 studies awarded. Now this is comprehensive, including, low studies at institutions all the way through and up to things like preventable big NIH grants, R01s, et cetera. And people have gotten funding from multiple sources. So AHRQ, Department of Defense, one of our investigators at our institution had a big DoD award to study heart disease in women in the military. CDC funding, I mentioned the COVID funding. I also have an R01 now to study chronic kidney disease of uncertain etiology as part of a NIOSH award for agricultural worker safety centers. NIH obviously is a big source. PCORI as well. Obviously, PCORI wants to see PCORI, patient-centered outcomes research done in PCORnet, a few industry studies, pilot funding. So, a little better than 50% hit rate so far, although 93 are pending. Now, we do require the OneFlorida Executive Committee approval, and you have a representative on the Executive Committee to approve studies. We've only denied 20 studies in 7 years now. 7+ years. So, it's 3 denials a year, and it's very rare. And if you ask me the reasons for denial, I'm not going to recall them very well, but ultimately it just centers around whether you're really using the network as a network resource. If you just want to do a UAB study, you don't need OneFlorida for that. And that's the additional logos of funding. So here's an example of a study done by an investigator at UF, Rhonda Cooper DeHoff. She's in our College of Pharmacy. She's got a strong research interest and has done a number of studies in hypertension. So they looked at, how much diagnosed versus undiagnosed hypertension is there in the state. Because we have vital signs data, they can look at blood pressure and, using various criteria, infer that somebody's got hypertension, even if it's not coded as a diagnosis, using something like ICD. So this looks at the geographic distribution of adults with diagnosed hypertension. You can see we've got what we call the stroke belt here in North Central Florida with the darker colors. And then if you look at undiagnosed hypertension, you can see the distribution shifts. So we have a lot of undiagnosed hypertension in the southern half of the state, and the far western reaches of the state. So that was an interesting result and an example of the kind of study you can do. We also have a number of publications out of OneFlorida. We've got a batch of PDFs we're happy to send out, publicly available, so we're not violating any kinds of copyrights, but we're happy to share those as well. This is a grant. The lead PI is Dr. Zhang Bian, who's biomedical informatics faculty. We're part of a CDC effort and that's another CDC funding that I forgot to mention earlier, about doing diabetes surveillance in the state. So there's 8 funded sites: so Florida, Cornell, Geisinger in Pennsylvania, Indiana, Kaiser. I think the Kaiser's California, PedsNet, Colorado, and USC. So developing computable phenotypes for children with diabetes within OneFlorida, doing population representative assessments. So this is a map. Again, I think our PhD geographer, who should be listed here, but I don't, maybe she's not, Jackie Hall, helped us with this map. So the market penetration map. And we want to do ultimately more real-time surveillance on young children with diabetes. This is the exposome data, so the particulate matter. So with Dr. Hui Hu, who was here in our Department of Epidemiology, has subsequently moved to Harvard. Again, you can see we've got this green dot is particulate matter 2.5 composition, criteria, air pollutants, vacant land, air toxicants, crime and safety, food environment, social capital, walkability, looking at all these factors and what's associated with, I think this, it's not mentioned here, but this is COVID-19 mortality. So what factors are associated with COVID-19 mortality? So PM 2.5 and criteria air pollutants are up there. This is past consortium, so this is Recover. I already talked about that, and I think you all might be familiar with it and participating as well. But the goal is just, study long COVID and what factors are associated with it, and what's the natural history, and how can we manage these patients as a certain urgent national research priority. Active 6 is another COVID study on drug repurposing to reduce COVID-19 symptoms. It's got 5 to 8 arms determined by existing active medication prioritization committee. They did look at ivermectin. I don't know if that's still under consideration or they closed that arm, but they're also looking at some other medications listed here, including metformin. So those are just some examples. That's an overview. This is a list of people who helped build OneFlorida and the Data Trust, a lot more, including your team and your investigators who are engaged on your subcontract on the funding. The Data Trust work has been supported by a lot of NIH and PCORI and statewide state funding and CDC funding, and briefly the People-Centered Research Foundation. That's a long, interesting story that I could tell you sometime. So with that, I can stop and take questions. I hope that's a helpful overview of OneFlorida and the Data Trust. I mentioned I2B2. I didn't really have a chance to demonstrate it since I don't. Sadly, your data is not yet included in the I2B2 instance, but it will be. We're actively working on it. So one question I see in the chat already from Jeff Curtis is, will your data automatically be part of the death data ascertainment? Yes, we're getting the national data from Datavant. So anytime there's a new patient that wasn't previously in the data set that gets linked, we link it. And then the previous question to that is the hash being used as a way to de-identify the patient and instead associate the other variables with the hash for models and analyses? So the hash is used to link a person's data across all the data sources. Yes, if there's a study that requires re-identification of the patient for possible enrollment, we will give you the hash that we have, and then you maintain the map at your site, your technical people, who will then map that back to whatever study linkage identifier you have at your site, and then can map that back to a medical record number, name, and et cetera. But we never see that here in Florida. But all the data about that person that gets linked, we have. And so hopefully that answers that. Does that answer your question, Hans?
Is it okay if I just talk to you for a little bit?
Sure.
Yep, go
Yeah.
ahead.
So it partially answers my question. I get that the hash is a way to coordinate patient data across the different records for the different institutions. But I was asking on the sense of if some research is being conducted that requires a patient to be to have some, let's say, social variables associated with the study, for example, for readmission or something like that, where we know that zip code is a relevant variable. Is using the hash way to maintain, because most of the de-identification methods that are currently widely used discard many of those variables, so they limit the scope of research that can be done. So that's my thought with the hash being used as a way to de-identify without necessarily sacrificing as much information.
So there's a couple thoughts I have and a couple things there. So one is we bring whatever data we have about the patient is all linked to the hash. So demographics, prescribing labs, vitals, diagnoses, procedures, everything that's there. You know, and then when you talk about social determinants, there's, you know, there's the discussion of individual level social determinants of health versus area level. So when we're talking about American Community Survey, that's area level. And so we're using, you know, sort of an aggregate indicator for the patient census tract. But we do link from their zip code to, you know, if it's a 9-digit zip code, we can link to their census tract and then link them to those social determinant aggregate, you know, level or area level social determinants of health through their census tract. And then when there's study data collection, usually what we do is we do a whole to link the study data to the data that are collected as part of the study protocol, electronic data capture, to the electronic health record and claims data. That's typically done through yet another Datavant hashing process. Done exactly the way we do it, to link all the electronic health record data for multiple sources, but it just uses a different encryption key and different token setup specifically for the study. Does that answer your question? And then the tokens are generated based on different combinations. So one token's first name, last name, date of birth. Another token is first name, last name, date of birth, gender. Another token is first name, last name, zip, and those kinds of things. We know which tokens were generated based on those variables, but obviously we don't get those data, right? Because we don't want in Gainesville the names of your patients. So that's on the sites to maintain those variables, first name, last name. All right, so I see another question in the chat from Jim Semino. What kinds of systematic biases are present in these data of which researchers should be read? That's a great question. So all the ones that are well documented in the literature and that I'm not very good at reciting by rote, but, you know, there's selection bias. You know, our patient population is nearly 60% female, whereas the general population is not, right? And that's because people self-select for that, for being in the healthcare system. So that's just one example. Also, if you're trying to rule out, you know, these data are good at identifying what does exist, but if you're trying to rule out the absence of something, you can quickly run into trouble. So if you want to know that the patient did not have a procedure, As our coverage gets better and we include things like claims data more comprehensively, you can have a little better certainty that, say, the patient never had a colonoscopy, but you should never assume 100% certainty that the patient never had a colonoscopy if it's not present in the data. So that's another caveat to using the data. And Jim, I don't know if there's other specific biases that you had in mind that you wanted to make people aware of, but those are the ones that I talk about.
Yeah, I mean, I think there's all kinds that could be related to, remember, we're getting only a piece of the patient's record, and we're only getting a piece of the patient's, right? So UAB is the 8th largest hospital in the country, but there's another big hospital, within walking distance, actually a couple, counting the VA, that we don't have any of their data, and a lot of the people overlap. So, which data are they getting done at which institution? And are there, disparities in the populations that are doing that? And similarly, how are tests being ordered? Maybe we order more tests on people with more, more insurance or better insurance. There's all kinds of things that, if you're not thinking about those, or you're not looking to see if there are differences, you might assume you're getting when you have big data, you think all those differences are just going to wash out. But when they're systematic, of course, that's when they don't wash out.
Right. Yeah, exactly. And to your point, Jim, despite being a relatively small town, we are not the only game in town. There's a large health system that's, I think, part of HCA in town, called North Florida Regional Medical Center. And so even in Gainesville, you don't know who's going to North Florida for stuff and who's not. And yeah, I mean, there's a lot of biases in healthcare generally that are surely reflected in the data. All right, another question is in chat, and I hate, I don't want to privilege the people putting questions in chat too much, but we got a good amount of time still for questions. Been asked by some AI machine learning folks about training algorithms with available clinical data. Have you addressed an environment or approach to do such work previously at OneFlorida? So we don't have anything like an enclave that people can log into and access the entire OneFlorida data set and run AI algorithms, and have AI analytics on high performance computing. So, we do cut record level data sets, HIPAA limited data sets, to investigators with IRB approval and OneFlorida Executive Committee study approval, and each site has to agree to participate to allow its data to go out as part of that set. And so people just do things that they can do locally in secure environments that their IRB approves. Some of the AI stuff we've done here at UF has been with our own health systems data on our own high performance computing. We had a donation from NVIDIA of a DGX SuperPod, and we use that to process clinical notes to build a large language model from our clinical notes. But it's really emerging and we're getting started. So we'd love to talk with investigators who are interested in doing AI machine learning with OneFlorida data about, what kinds of things you're trying to do and how we could be of service, and what kinds of infrastructural things we might be able to co-develop ultimately.
Thanks, Bill. I know that Hans basically lives in that AI ML world, and he's one of the people that's been asking me about it. So maybe we can pass your question on to him.
Sorry, I'm having connection issues. I lost part of what just happened. I just got called into the, the spot here.
So no worries. So we were discussing AI and machine learning and what kind, have we addressed an environment or approach to do such AI machine learning work previously or at OneFlorida? And my answer to the question is we've done things just at our own health system. We've given data to other investigators who have sort of done their own things at their institution. But we haven't done anything systematically OneFlorida wide, but we're very interested in what kinds of things you're trying to do and what the needs are and how we could work together. And so the question to you is just what kinds of AI, ML things are you interested in doing, and what kinds of things did you have in mind?
Right. So there are many different approaches that we can take to analyzing medical data. I think a lot of emphasis has been put into diagnosis models recently. I don't think that's probably the best use of the data, but there's a lot of things that can be done with early warning, just sort of predictive trends in vital signs metrics, and just overall kind of for hospital populations is as a smaller subset of countrywide populations, for example, to have predictive data on patients that may need higher levels of care before we realize they need higher levels of care. So just along those lines, there's a bunch of things that can be done. But the real big challenge is data collection for these types of predictive models to be accurate enough. And just the way the data needs to be structured and organized, I guess. It's a little bit different than what we usually do.
Sure. So it's a great point. So I have a couple thoughts. We have a physician scientist here who's just became our senior associate dean for research in our college, actually, Azra Bahorak, and she's been doing a lot of this work on models predicting sepsis and other surgical complications from using the physiological monitor data, and that's a whole big setup and world, and those data are even bigger than what we have already. So getting those data in a kind of systematic way is a big lift, and we've done enough to build models and validate them here, but not enough to make that kind of research a regular, reproducible per se, or implement the models very well in practice, although we have tested them some. So yeah, it's a really interesting area, and does require lots of organization of the data and a lot of engineers involved in that project using novel kinds of big data infrastructure. I'm trying to remember the names of some of them. It's been a while since I've been directly engaged in that project, but yeah, I mean, we'd love to connect you with our folks working in that area and think about how we could do that, and if we can start moving those kinds of data into OneFlorida site by site, or figure out how to do it in a more federated fashion if the data are just too big. Our infrastructure is already straining under the load a little bit. But if we could, we just figure out what models work and what's feasible, we'd love to engage you in those kinds of things. And she's part of I'm blanking on the NIH AI funding awards that just went out.
Bridge to AI.
Sorry?
Is it the Bridge to AI?
AI, yeah. Yeah. So she's she's site PI on a bridge to AI that's looking at these kinds of physiological monitoring kinds of data. And I have 1 or 2 faculty in my division of biomedical informatics who are co-Is on that project.
Any other questions, folks? Thanks for the great questions, and for those who have
Wait,
stuck around till the
I
end.
have one more.
Oh, yeah, please, go ahead.
I was typing it and then you chimed in, so I'll just speak it. The data trust, is that on campus? Is it on premise, or are you using commercial cloud resources? And I guess why?
Now it's in a data center in Gainesville. Yes.
Okay.
We have had discussions about cloud. That makes some of our healthcare system partners very nervous. And so we had actually just wanted to do a test where we'd move data to Amazon, run some tests, and then delete it. And we didn't even get that far yet. Some of our partners are going to want high trust certified environments, which Amazon does have available, for example. But we're having those discussions, and we think we're going to end up there eventually, but not in the next 6 to 12 months, probably.
Well, and there's also the budget side of that too.
Well, yeah, we do get some benefits to being internal cost-wise and human resources-wise, but they're starting to dwindle. So the Amazons and Azures of the world and Google may be competitive sooner than we'd like.
Thank you.
Other questions, comments?
We're actually
Either in the
doing
chat?
testing with synthetic data on Amazon. For the PCORnet does a data quality checking process once a quarter. It's called empirical data characterization, or EDC. And the SAS code they send us for EDC takes us, on some data sets, it takes 5 days to run. So like the Florida Medicaid data, it takes 5 days to run in the PCORnet common data model. And our SAS server, just for the first time, tripped some new errors we didn't see before this October. And so, yeah, we're straining on storage, we're straining on compute. So we would love to have scalable infrastructure that the cloud can provide. Hans, sounds great. We'll follow up offline.
No, we just have about 2 or 3 minutes left. Any final thoughts from our distinguished audience?
I didn't put the URL in. It's OneFlorida Consortium.org. And there's various links there. And I can send those as a follow-up. And I think we can make these slides available too.
Yeah, and the presentation is recorded, and we will be
Right.
putting that on our usual channels for recordings. So if anybody wants to, if anybody couldn't make it and wants to still attend. Well, if none, hearing none, always feel free to follow up afterwards. And thank you everybody for attending. Thank you, Dr. Hogan, for a wonderful presentation. And and it's really real for me, because I've been involved in some of the efforts to send our data over to you. So I appreciate you.
Thank you.
Helping everybody make better research and across different institutions. We hope you can join us for the next Power Talk. Otherwise, I'm going to sign off for now, and have a great weekend. Bye.
Thank you.